It's my pleasure to introduce this morning's grand rounds, which is on nutrition and trauma, something I think we all think about and at some gut level feel is extremely important, particularly for certain populations of patients. And we actually have national experts in our institution who have studied this for many years. And so this morning, Cliff Ho is going to lead this and has put grand rounds together. Cliff, you're actually going to have to say something this morning. Along with Cliff, we have our assistant professor, Reza Firoozabadi, who has an interest in this and has started to work on some aspects of this with metric. And then a good friend of our department and mine, Grant O'Keefe, who's a professor in surgery and also an adjunct professor in our department. And I know that Grant for many years has been funded to study the role of nutrition in trauma. And then Brodie Parent, who is a general surgery resident who is going for his master's degree, MPH, and has been working with Dr. O'Keefe on this topic. So we're very grateful that you could come and do this for us this morning.
Thank you, Dr. Chansky. So we have a lot on the docket this morning. Let's go ahead and get started here. This morning I'm going to be talking a little bit about, with a brief introduction for Reza, Brodie, and Dr. O'Keefe. Reza will give a little short talk on nutrition and orthopedics. Dr. O'Keefe will follow, focusing on nutritional care in polytraumatized patients, and Brodie will finish using metabolomics to discuss novel methods of nutritional assessment. So during my introduction, we'll give brief methods of nutritional assessment, talk about the post-traumatic metabolic states, and begin the discussion on nutrition and trauma in orthopedic patients. So the World Health Organization has a very complicated definition of malnutrition. It is simultaneously a nutritional deficiency or excess and health outcome, as well as a risk factor for disease. As we'll see, an additional layer of complexity lies in the difficulty of accurately assessing nutritional status in polytraumatized patients. So a physician's assessment of baseline nutritional status starts with a thorough history and physical. Care is taken to focus on coexisting medical comorbidities, review of dietary habits, as well as social history, patient's level of functional independence, physical activity, history of substance abuse all provide insights into a patient's ability to obtain or maintain nutritional health. More objective measures are available on physical exam. Parameters such as BMI, tricep skin fold thickness to arm circumference ratio have all been used in the past, and historically muscle wasting and scaphoid abdomen are signs of malnutrition. However, these are only present in the presence of chronic nutritional deficiency. Another objective method of assessing nutritional status is calculating the balance between caloric intake and daily energy expenditure. As you can see from this table, energy expenditure depends on patient age, gender, body weight, and activity level. The average daily caloric requirement for a 70 kilogram male is approximately 1,800 kilocalories per day, and care should be taken to calculate this specifically for every patient upon intake. Laboratory nutritional assessment utilizes serum biochemical markers of hepatic synthetic function, as well as other immunologic surrogates. These include albumin, prealbumin, transferrin, and total lymphocyte count. The Rainey-McDonald Nutritional Index is a validated nutritional assessment tool which utilizes some of these variables, and in conglomerate with history and physical, these tools can be utilized to assess baseline nutritional status, but their use in acutely assessing the nutritional status for post-traumatic patients can be limited. Acute nutritional assessment is challenging because anthropometric parameters such as BMI have been shown to have a poor correlation with body composition, and in addition, serum markers such as albumin and transferrin have long half-lives and may be insensitive to abrupt changes in nutrition. Prealbumin itself, though, has been thought to be the most sensitive and responsive. Its levels are still affected by hydration as well as renal and hepatic function. Patients who have sustained a severe trauma typically mount a hypermetabolic response. This is seen with an activation of systemic inflammatory response cascade, and these patients develop a state of net catabolism. This is characterized by protein depletion, insulin resistance, as well as skeletal muscle breakdown. With these changes, nutritional stores may be depleted rapidly, all while physical exam findings and some laboratory markers have not changed appreciably. So the post-traumatic hypermetabolic state was first proposed by Scottish physician David Cuthbertson in 1930. Particularly in relation to orthopedic trauma patients, he found that patients who have sustained long bone fractures typically develop weight loss, tissue wasting, and a negative nitrogen balance, even when they were maintained on a preset diet. As you can see, it's pretty delicious. We have dried apples, dried tomato soup, and tea, so very generous of them. In regards to hypermetabolic state, Planck et al. Published a prospective observational study of trauma and sepsis patients who required prolonged hospitalization and found an increase in resting energy expenditure in the first few weeks following their admission, the 40% increase above baseline in the first week and 100% increase above baseline in the second week. These patients also sustained a 13% loss in total body protein over 3 weeks. Further evidence for the importance of nutrition in orthopedic patients was provided by Jensen et al. In 1982. With specific regards to orthopedic patients, they found that their trauma patients had a 58% incidence of laboratory or exam malnutrition after admission. Trauma and major surgery was seen to induce a state of malnutrition as well as loss of immunocompetence, and this was manifest by a decrease in total lymphocyte count and a loss of reactivity to skin antigen testing. More recently, evidence for the negative association with protein depletion in orthopedic trauma patients was provided by Patterson et al. And a group at HSS who found an over 50% incidence of protein depletion in their geriatric hip fracture population. This state of protein depletion was associated with a higher complication rate with delayed wound healing and sepsis, a longer hospital stay, and a decreased 1-year survival. In summary, nutritional assessment is challenging. There is a catabolic state after trauma, and orthopedic trauma patients demonstrate evidence of impaired nutrition, which is associated with worse clinical outcomes. At this point, I'm going to turn the podium over to Reza. Thank you.
Thanks, Cliff, for that excellent introduction. So I'm just going to back up what Cliff said and add some new information to it, focusing on the orthopedic trauma patients. So I'll give you a little bit of background. Then we're going to change gears a little bit and look at these laboratory markers and see exactly what they are. Then look at 2 studies that we performed at Harborview. The first study is looking at nutritional status in the orthopedic trauma patient. And the second study is one that we're nearing completion now, looking at ways we may potentially be able to improve the status of these patients, and do the ways that we think improve status really improve their nutritional status. So really, malnutrition is the imbalance between dietary intake and the patient's energy requirements. On the dietary intake sides, trauma patients a lot of times are nauseous, they're made MPO on multiple days, they don't want to eat, or they're intubated, so intake's definitely affected. And as Cliff said, on the energy requirement side, they require increased calories due to the fact that the requirements go up roughly 15 to 25% in trauma patients. And when you consider polytraumatized patients, specifically patients that go on to develop infections, this requirement can go up 100%. And poor nutritional status has been shown to be a risk factor for wound healing, complications, infections, loss of muscle, as well as mortality in the general surgery literature. What do we know about nutritional status and how it affects patients in orthopedics? It's been poorly studied in orthopedic trauma, but in terms of spine patients, this has been studied extensively. And the first person that really looked at this was Klein in the mid-1990s, and he looked at lumbar spine patients. These were elective patients, and he noted that about 25% of the patients were malnourished. Of the patients that got infected, about 85% of them were malnourished, and he made the conclusion that malnourishment will potentially lead to increased infections in spine patients. In the arthroplasty literature, a lot of this data is based on the Scandinavian registry data, and what they've noticed is that patients that are malnourished have more wound healing complications. And as Cliff alluded to, in the hip fracture population, a large percent of these patients can be malnourished, and the reported range is anywhere from about 6 to 78%. So changing gears here a little bit and looking at the nutritional markers and the players that are involved. So everybody's heard about albumin. It functions as a carrier protein. It really maintains oncotic pressures. It has a very large body pool size, and only about 5% is synthesized on a daily basis. It's distributed in the vasculature as well as in the interstitial space, and it freely floats between these two spaces based on oncotic forces. It's a negative acute phase reactant, so when there's inflammation, it goes down because the body utilizes its resources to make inflammatory mediators. And its half-life is relatively long on the roughly 14 to 20 days. Prealbumin is a transport protein. Unlike albumin, it has a very small body pool size, and its half-life is 2 to 3 days. And because of these two reasons, it changes more rapidly with intake and energy requirements. It's also a negative acute phase reactant. It's degraded by the kidneys, so patients who have kidney dysfunction could have artificially elevated prealbumin. Transferrin, it's an iron transport protein. It's got a small body pool size like prealbumin, but unlike prealbumin and like albumin, it has a long half-life, and it can be elevated during states of iron deficiency. Now, CRP is C-reactive protein. This is an acute phase reactant, unlike the other proteins that we just discussed. It goes up during times of inflammation, and its half-life is roughly 19 hours. So now that we know some of the players involved in assessing nutrition and some of the inflammatory mediators such as CRP, let's look at our first study. So the purpose of this first study was to investigate the prevalence and evolution of malnutrition in our orthopedic trauma population. There's no real good studies out there that do this in this specific population. And then we want to determine if malnourishment increased the risk of complication in these patients. Patients that were on the orthopedic service as the primary team were included in this study. So usually these are patients with one or two fractures. Polytraumatized patients were admitted to the general surgery service as well as the ICU patients, and these patients are excluded. Patients were 18 years and older. If they didn't speak English or Spanish, they were also excluded. Laboratory markers were obtained on admission, day 3, day 7, and if they're deficient on discharge, they were obtained at 6 weeks. We looked at albumin, prealbumin, transferrin, CRP, and vitamin D. And as Cliff alluded to, we looked at the Rainey-McDonald Nutritional Index, which has been correlated with mortality. A value less than 0 is indicative of malnourishment, and the more negative the number, the more likely you are to be malnourished and a higher risk of mortality. There was 84 patients total. Age was about 51 on average, BMI of 28. About 24% of the patients had more than one orthopedic surgery, and median length of stay for these patients was 6. When you look at the type of injuries they had, again, most of these only had 1 to 2 fractures, and there's a variety of different fractures that these patients had, so there was a nice mix. Now, looking at the nutritional markers, specifically albumin, prealbumin, transferrin, and the RMNI, what you can see is that there's a trend from admission to hospital day 3 to hospital day 7, that these nutritional markers decrease over the acute hospital stay for all 3 markers as well as the index. Interestingly, when you look at CRP, on admission, the average CRP was 27.8. It went up to 93 on day 3, and it goes back down on day 7 and normalizes by the 6-week follow-up. And when you look at vitamin D, the vitamin D levels on average were very low in our patients, average being 20.1 on admission, and at 6 weeks, 28.4. And these are just spaghetti plots. All this is each individual line represents a patient in this study. And what you can see for the top plot is that for prealbumin levels, if you look at from admission to day 3, there's a significant drop in the level of prealbumin. But once you go from day 3 to day 7, it really stabilizes. Some patients go down slightly and some go up slightly, but there isn't as much of a dramatic change as you see from day 0 to day 3. And same goes for the RMNI index on the bottom plot. Now, looking at this in a little different perspective here, when we look at this, we see that based on albumin, which is the blue graph, on admission, about 70% of patients would be diagnosed as malnourished. On day 3, this goes up to over 90%, and it stays high by day 7. If you look at prealbumin, which is the yellow graph, about 40% of the patients are malnourished on admission, and it goes up to about 90% and it stays relatively high. And much the same for the RMNI, and about 25% of the patients are malnourished on admission, and by day 3 it's roughly 70%, and it comes down to about 42% on day 7. And you can see the trend with CRP here, because everybody's CRP levels were drastically elevated. If we use the normal cutoff of CRP of 10 as being elevated, then 100% of the patients would be malnourished, would have elevated CRP levels on day 1, day 3, and day 7. So we divided these patients up into quartiles, and the top quartile we called severe acute phase response. And you can see here that based on that, about 25% of the patients had markedly elevated CRPs on admission. It goes up to about 68% on hospital day 3, and it comes down drastically to about 42% on hospital day 7, and normalizes at the 6-week follow-up. So is there any statistical significance to any of this? So when we break it down from day 1 to day 3, looking at albumin, prealbumin, and the RMNI, they all come down, and they come down, the change is significant. When we look at CRP, it goes up about 3-fold, and that change is also significant. Now, when we go from look at day 3 to day 7, are the values any different on day 3 to day 7? For the nutritional markers, they're not. They're roughly the same, and it's not significant. But CRP comes down, and that's significant. Now, when we compare day 1 to day 7, you would suspect that this would be statistically significant due to the fact that the values don't change very much from day 3 to day 7, and that's the case. There's a significant change between day 1 and day 7. So what about complication rates? This is really what we're after, and that's what a bigger study needs to be done to assess this. We had 7 complications. Specifically, these are wound infections or infections requiring antibiotics. That's 7 out of 84. But when we compare those patients, the complication patients, to the non-complication patients, how are their nutritional values? Are they any different? So based on albumin and the RMNI, they are different. They're significantly lower in patients with complications. And when you can correct for injury severity score, prealbumin is also statistically significant. So this would suggest that patients that have poor nutritional values are at risk for complications. But again, these are very small numbers, so I don't want anybody to draw definitive conclusions based on that. How about the elderly patients? In the hip fracture world, this is the focus on the elderly patients. We divided up patients under 60 and over 60. Sorry, Brad, you fall in the elderly group. So when you look at this, when we looked at BMI, admission CRP, day 7 CRP, 6-week CRP, admission RMNI, we saw no significant difference between those two groups. They were roughly the same. Interestingly, when you look at the day 7 RMNI, you see that there's a significant difference. The elderly patients are markedly more negative than the younger patients. This is suggested that elderly patients are more at risk for malnutrition than younger patients. Another interesting point here is when you look at the vitamin D. So there's a lot of emphasis now being placed on vitamin D. On admission, the younger patients had on average a vitamin D level of 19, which is poor, and the elderly patients had a vitamin D level of 26. When you look at these patients at the 6-week follow-up appointment, the young patients, the vitamin D level has not improved. And the elderly patient, it's improved drastically, where most of them have normalized their vitamin D levels. What this is telling me is 2 things. 1, we're really focusing our attention on making sure that the elderly vitamin D levels are normalized. And 2, maybe we're ignoring the young patients, or the young patients are not being compliant with their vitamin D supplementation. So really, we should try to focus also on the young patients. We're doing a good job with the elders, but not the young patients. So the take-home points from this first study is that orthopedic trauma patients are malnourished, at least based on laboratory findings. Their nutritional status declines through the hospital stay. CRP does peak, and then it comes down by day 7. The nutritional labs don't drop, they stay elevated. Patients with complications have no lower nutritional marker values. Elderly patients are at risk for malnutrition. Vitamin D deficiency is a major problem in our patient population, and we shouldn't ignore the young patients with vitamin D issues. So moving on to the second study, and we just finished enrolling for these patients. So the part of this data addressing the second aim is incomplete, so I won't be presenting that. But looking at the aim of this study was to determine if our intervention, that being nutritional consultation and protein supplementation, could this prevent malnutrition in the orthopedic trauma patient? And secondarily, to see if our intervention could decrease our complication rates in these patients. So this was a randomized prospective study that we did at Harborview. There was a control arm and the treatment arm. In the treatment arm, patients underwent nutritional counseling by one of our excellent registered dietitians at Harborview on admission. They were ordered for protein supplementation with every meal on admission. There was a study assistant that walked and saw these patients every day from admission till discharge and reminded them of the importance of nutrition and made sure that they were getting their protein supplementation given to them. So what did we see in these patients? So there's a control arm and a treatment arm. When we look at age, BMI, length of stay, and admission laboratory markers, there's really no statistically significant difference between the two groups. And each group had 40 patients. And so at baseline, they're roughly equivalent in regards to the treatment group and the control group. Now, we didn't get the results we expected to get. Okay, when you look at patients at day 3 and day 7, there's really no difference between the two groups except one value. Albumin at day 3 tended to be slightly higher in the treatment arm versus the control arm, but everything else was the same. And we thought that our nutritional intervention and counseling could potentially help these laboratory markers and prevent patients from being malnourished based on these laboratory markers, but this is not the case looking at this data. So what can be going on here? So to answer our primary aim, based on these laboratory markers, nutritional status didn't improve with our counseling and supplementation. What does this mean? What this means is that maybe we don't know how to appropriately assess nutrition using these laboratory markers. Maybe we're missing something. And what will be really interesting is once we get through the next 6 months and we look at patients who had complications to see if our treatment group had less complications than our control group. Because even though we don't see a change in the nutritional markers, it could be that we are not able to pick up the changes with these nutritional markers in the acute trauma setting, but it could have a difference in regards to outcomes for these patients. So to conclude, malnutrition can lead to poor outcomes. Orthopedic trauma patients are understudied, but malnutrition is a problem in this patient population. Nutritional status declines during the acute hospital stay. Counseling and protein supplementation doesn't affect these nutritional markers. And really, we need to come up with potentially new techniques to study nutrition. And this is a perfect segue in introducing Grant O'Keefe and Brodie Parent, because they're at the leading edge of this stuff. They really know and are studying different techniques that we can use that can potentially pick up the differences, if there is any, in this challenging patient population. Thank you, and I'd like to especially thank Benjamin Hamilton, who is a medical student from Case Western, who spent about 8 months on these projects with us this year. Courtney O'Donnell, who spearheaded this when it first started about 2.5 years ago now. And lastly, the Department for Resident and Faculty Startup funding for this project. Thanks.
Good morning. I'm really pretty thrilled to be here. But actually, I'm probably even more excited about the work that Reza is doing, because I think it really fits nicely with a lot of the interests at Harborview in terms of nutrition. There's just a wealth of resources there and people who have been doing this for years and years. And I'm only one of many. What I'm going to talk a little bit about today is, I think it fits nicely with what Cliff and Reza had talked about, is this other group of patients who are perhaps a little more critically ill and in whom we have to control their nutritional support a little bit more than they control it on their own. course, it's important to know who's talking to you, and I'm just going to, we don't have a lot of time, but I'm going to take a couple of minutes to tell you where I come from, not because the story is particularly interesting, because it might inform a little bit about what I'm doing. No, that's not what I want. I grew up in Edmonton. It's a very beautiful city, lots of snow, and today it's really pretty cold. I went to medical school there and did a rotating internship in St. John's, Newfoundland, and really basically flew over that part of Canada that doesn't particularly matter to most of us. Yeah. Well, I'll talk a little bit about sports in a moment. No, I'm not a Patriots fan. So in Newfoundland, when you come from there, go there from somewhere else, you're supposed to get initiated into the culture. And that involves drinking rum and kissing a cod, being called screeched in. And I think perhaps this is where I got my interest in nutrition, alcohol and fish. One of the places where I was screeched in is this place called Trapper John's. And because it's a bar, they can't have live animals or dead fish in there, you have to kiss a puffin's ass. So that's the screeching in process. So having experienced that for a year, I went back to Edmonton and did my surgical residency there. And this was in about 1989. Now, I'm here because I'm not in Edmonton, and I'm interested in nutrition, perhaps because of alcohol and fish. There's lots of things to talk about in terms of nutrition in the intensive care unit. Route of administration, how and when we feed, a lot of, I think, pretty fascinating things about the pharmacology of nutrition. I think both of these are to a certain extent, Reza and Cliff alluded to. And the use of guidelines in evidence-based medicine, and on top of that, beginning to apply what we refer to, and many of you are aware of, as precision and personalized medicine. The idea of trying to identify exactly what a patient might need, rather than just applying guidelines. As you can imagine, much of what we do, we kind of think it's sort of in this scenario where it's very controlled. The guy in charge says, tells everybody what to do, and they do it. But in fact, the fact is that it's pretty much pandemonium. And this is a pretty good example of our ICU, really, is that there's a lot of pandemonium. The guidelines are kind of meant to help minimize that. And we have a pretty established and I think pretty robust approach to nutritional support. Some of the data that I'm going to show now comes from a lot of patients, in fact, that many of you have taken care of. We were involved with what was referred to as the GLUE grant, or the Inflammation of the Host Response to Injury Consortium. And the focus of that was to try to understand a little bit more about the metabolic and the inflammatory response to injury. As a part of that, we recruited overall about 2,000 patients, and about 800 of those came from Harborview. And that's what I'm going to talk a little bit about now, is some of the nutritional support issues in that group of patients. And as many of you know, our approach generally is based upon enteral nutrition, where we feed everybody as aggressively as we can enterally, and reserve parenteral nutrition for those people that we can't feed. Now, it's interesting because what we know is that of these markers that Reza mentioned and some of the things that Cliff mentioned, I can fix those in a couple of days with parenteral nutrition. I can fix somebody's albumin, and I can fix somebody's pre-albumin simply by giving them a week of parenteral nutrition. But what we know is that doesn't make any difference in their outcome. So this is our protocol. I just put it up there to show you because we actually do things with a little bit of reason in the ICU. I know, even though all of you kind of think that we're trying to keep you from operating on your patients. So the first thing I'm going to talk a little bit about parenteral nutrition. It has a long history. In fact, it goes back to these fellows and also to Cuthbertson, as Cliff mentioned. And Cuthbertson and a fellow named Dudrick are probably the people that general surgeons can consider as the people who are most important in the area of metabolism and surgical nutrition. And I just want to bring this up because both of what they're telling us here is that is that parenteral ways to support nutrition is physiologic. But of course, we know that this really isn't the case, because fetal parenteral nutrition is really still delivering the nutrients to the GI tract, but or to at least to the splanchnic circulation. So this really had led, or these two folks really led to a lot of interesting and important studies that kind of resulted in this sort of uncertainty about where parenteral nutrition comes into managing our badly or severely injured patients and other critically ill patients. So early on in this glue grant experience, what we did was, Matt Sena was one of our fellows, and what we were wondering was, what is the role of parenteral nutrition in these patients? And this was at a time when it was very controversial. There were a lot of places that were actually treating people fairly early with parenteral nutrition. It was a widely established approach, particularly in Europe. And so we had the opportunity to look at our guidelines. And as I said, they're not rules. People had the opportunity to take care of patients slightly differently. So even though our approach was to focus on enteral nutrition and to not use parenteral nutrition in the early time, there were patients that did get parenteral nutrition early. And this is just a quick summary of that. We initially had about 550 patients in the cohort, and what we focused on was the patients that early on in that first week received some enteral nutrition, or enough enteral nutrition that we thought they were getting close to sufficient support. And there was a small group of those that somebody decided to supplement them with parenteral nutrition. Now, at the time, that was a very reasonable thing to do. This is now probably about 8 years ago. And this is just a quick summary, and what I want to show here is that they truly were different in terms of the amount of parenteral support that they got. What this shows is in the group that didn't get any parenteral support, they didn't. A little bit of this is because we measured glucose and fat in the propofol, so they weren't getting parenteral nutrition. But this group was. And what's interesting is that they were getting essentially the same amount of enteral nutrition. So basically, we were just giving them more. And what we found, in really briefly, is that those patients that had parenteral nutrition that had supplemental parenteral nutrition, particularly in terms of bloodstream infections, they had a much higher risk. And they had a slightly higher risk of death too. Now, we don't know if this was just because they were different in terms of their injuries, or if it was a true effect of the nutritional support. But the point was that there was clearly some negative effects of the parenteral nutrition. And then this just shows in the parenteral nutrition folks that they had a higher risk of bloodstream infections, which typically began at around 5 to 7 days. So what this showed is that this ability to give people more calories really didn't improve their outcomes. So over time, lots of things have changed. Based upon that data and obviously some other things, our care has evolved. And I want to show a little more data based upon that data set now. But what we've done is parenteral nutrition use has substantially dropped, and also our bloodstream infection rate has dropped in the same cohort of badly injured patients. So what we did was then we went back and looked at these patients more recently and looked at them all and tried to understand a little bit more about how we supported them. And the next few slides, again, are now on the same cohort, but over the entire period of the study. And what I'm going to show, basically, is we divided these patients up into groups based upon the amount of feeding that they got early on. So the first group, or the most poorly nourished group, got essentially no calories in the first week. The second group, we fed a little bit, but for whatever reason, we weren't very successful. And as you can see, really, we increased the amount of nutrition that they got subsequently, but not by a great deal. The next group, a little bit better. And I'm just going to skip on to the fifth group, because this is the group that we sort of think that we want to achieve. This is the group that we want to have, that in trauma patients, that very quickly we get them up to what our target nutritional support is, which is about 25 kilocalories per kilogram. And that's what we want. But it turns out that of our couple thousand of patients, really very few of those patients actually fit into this group. So when we look at how they did, I've excluded the first group here because for a variety of reasons they're a little bit different. Not surprising, the patients who were fed relatively poorly enterally, they had more, they received more parenteral nutrition. They had lots of bloodstream infections. But what was surprising was this little bit here, is that the patients that we were more successfully feeding had the highest risk of pulmonary complications. So this made me wonder, are we perhaps hurting them? Now, sometimes we see them aspirate, and we know that when you feed people, they aspirate a little more often. But the question was, were we hurting them? So we went back and looked at our data a little bit more. And this is just sort of a summary of that. And what you can see is that the patients that had ARDS, we were better at feeding them. So the question is, were we hurting them by doing this? So going back, looked at a few things, but one of the things that we know is that in about 2006, we made some changes here at Harborview. And one of those changes was that in the past, and still at most places, when an ICU patient goes to the operating room, we stop feeding them about 6 hours before surgery. And imagine just thinking about our system, how much that interferes with their nutrition. Oftentimes patients are on the add-on list, they get scheduled for surgery, but that doesn't happen. So what we would see is huge caloric deficits. So we decided that we would feed these people right up to the time of surgery. And now I look back at that and I wonder, were we hurting people by doing that? So we went back and we looked at our data. And so this is that, again, the amount of calories per day at Harborview, just looking at the Harborview patients now, amount of calories per day over that first week in the patients before. And what you can see is that comparing prior to after 2006 is that we actually were giving people more calories overall, but look at all this variability here. There was so much variability both at the upper end and the lower end, and that was kind of surprising. And then we look at the non-Harborview patients, we see that there's a ton of variability there too from day to day, and there were no changes before 2006 and after. They didn't institute this change at the other hospitals. So let's go back to this for a moment, because here we have less calories overall in the first week and more variability. And it turns out when we went back and looked at our patients that this was the group that had the highest risk of pneumonia and the highest risk of ARDS. So in fact, instituting this protocol where we fed people a little more aggressively seemed to result in more consistency of feeding and actually reduced, even though more calories were given, actually reduced the amount of complications that they had from a pulmonary standpoint. So that was good news. So what we showed was that there's a little less variation in delivery of calories in the first week. Very few patients actually had no calories. There were much fewer higher outliers, and I think that this is the critical piece. We had much less parenteral nutrition use, fewer bloodstream infections without any increase in pulmonary complications. So as we go forward, how are we going to finesse nutritional support anymore? And I think this is sort of where the future is not necessarily in applying guidelines. The guidelines are important as a background, but I think every patient is obviously a little bit different. And how do we decide how to feed an individual patient or whether or not they would benefit from TPN? I think that that's the future, because I think it would be wrong to say that TPN isn't appropriate, but we need to figure out when and who is going to benefit from these things. Lots of advances in trauma care in the ICU and elsewhere. We just talked about nutritional support. I think this is really critical. There's a lot of things that we don't know, and hopefully some of the work that Brodie's doing is going to help inform us of those things.
Thank you for the opportunity to speak. I'd like to talk to you all about a little bit what I do for my research years. I think this is particularly relevant for Reza's study because he was talking about how he wasn't really seeing changes in these markers. And I'd like to argue that I think we need a new set of markers. I think we need something that's going to show us a little bit better what's going on with nutrition. So our plan, I'm going to be telling you a little bit about some of those controversies and outcomes. I'll be brief because I know we've heard a lot about that. And then I'd like to show you how metabolomics could potentially fill the gaps in our knowledge. And I'll give you some of our preliminary data as well. So this is why nutrition should matter to every doctor. Malnutrition is prevalent about 40% in our American ICUs. And for all the reasons that we've seen, it really impacts things like length of stay, nutrition, bacteremia, mortality. We know that we can decrease those complications by supplementing, but Dr. O'Keefe also reviewed that our nutrition methods also have their own morbidity and mortality. So like any therapy, we have to balance the risks and benefits of nutrition. There's lots of unanswered questions, and there's multiple studies which vary the different types of delivery, the types of nutrients, and the amounts of calories. A lot of these studies give directly conflicting conclusions, and I think that's due to a lot of the imprecision that we have. We don't really have a good set of markers to assess exactly what's happening to our patients as we give them these varieties of interventions. So we have the sense that we care about nutrition because it seems to impact important outcomes, but we're left not really knowing exactly what to do because our data are conflicting. And I would argue that the main reasons are these nutrition markers that Cliff outlined to you, as well as Reza. These are kind of limited. They don't account for individual variation in energy needs, and we've seen that's particularly important in the trauma population. They also don't really show us if the substrates that we provide to patients are actually being used. And then finally, they don't really correlate with any clinical outcomes. So I'd like to tell you a little bit about metabolomics. This is the study of the fats, amino acids, and proteins in the blood, which give us kind of a broad overview of the instantaneous physiology of an organism. It's downstream of genomics and proteomics, and is a study of kind of entire pathways rather than individual metabolites. So that improves the power of our analysis. There's kind of two subdivisions of a human metabolome or of any organism's metabolome. One is endogenous, the other is exogenous. Endogenous are the intrinsic metabolomic pathways that we remember from med school. Exogenous are factors like diet, drugs, exercise, gut flora. So prior studies in metabolomics have shown some promise in finding earlier diagnoses and treatment monitoring for things like cancer and critical illnesses. There's been limited work in nutrition, but applying some of these techniques could help us track treatment progress, response to therapy, and could help us better decide on when to actually start and stop some of these therapies. Just a little bit more on metabolomics. You can use pretty much anything you can think of to get a metabolome. I underline blood and urine because these are readily available and require minimal processing. The main tools that we use to analyze our samples are nuclear magnetic resonance and mass spectrometry, which both have their own advantages and drawbacks. The ideal world is actually a combination of these two tools, and I'll tell you a little bit more about that. Just briefly, two studies before I show you our data about prior metabolomics work in trauma. The first is this Chinese study from 2009. It actually looked at 3 different groups. 2 groups were trauma patients, about 30 of them with SIRS, 30 with multiple organ dysfunction, and then 30 healthy volunteers. They did some NMR-based metabolomics, and they actually showed that they could distinguish pretty nicely between the patients and the healthy volunteers. And if I showed you a different graph, you would see a split between the SIRS and the multiple organ dysfunction patients. The green circles on this graph are the healthy volunteers. Moreover, they found some biomarkers which are consistent with known physiology. And those are kind of the basis of how these patients are distinguished, mainly markers of muscle catabolism and lipid catabolism and fatty acid oxidation. Just a follow-up study in 2010 by Kinross. This is actually a mouse model. They did an XLAP and measured the metabolome before versus after in these mice. Again, they found markers of muscle and fat catabolism, but they also found impaired evidence of microflora metabolism too. So there's something about an XLAP that decreases microflora activity. I tell you these studies because these are all potential targets and all potential biomarkers for nutrition assessment. So our pilot study, we're interested in showing that metabolomics can be a useful tool in nutrition, may find biomarkers, and may improve outcomes. We're hopeful to show that we can distinguish healthy versus control, and distinguish anabolism versus catabolism. So just a little bit about our design. This is a pretty humble beginning pilot study. We're recruiting 20 patients. The inclusion criteria are blunt trauma and evidence of shock, systolic pressure less than 90 or a base deficit greater than 6. Those exclusion criteria are on the basis of what's likely to be a confounding factor. And then we had 20 healthy volunteers. We obtained blood and urine on the basis of this protocol, and then did some NMR and mass spec based analysis. We performed NMR for the urine specimens. It's pretty minimal processing. We just added a buffer to make it less acidic, and then we added an internal reference compound, which I'll tell you about in a little bit. Just a refresher on NMR, which you'll probably remember from your Gen Chem days. It's on the basis that all atomic nuclei have a spin and as well as a charge. When you apply an external magnetic field onto nuclei, they all align with or against it. Once that magnetic field is removed, the nuclei relax back to a random spinning state, and they give off a characteristic frequency. That gives us a readout, which looks like this. And this is actually one of our patients and one of our controls. On the far right-hand side, you see our internal reference, which has the lowest resonant frequency, and then on the far left are the higher resonant frequencies. The x-axis is parts per million, which is a derivative of frequency, and the y-axis is intensity. Intensity is directly proportional to the concentration of these metabolites. There's a bunch of information you can get out of this. A lot of this is related to how to directly identify these compounds, splitting of signals, distance from the reference compound, all of this. If we zoom in and actually put the identification labels on these, you can see in our trauma patient that we do have markers of muscle catabolism as to be expected, tyrosine, phenylalanine. There's also a decrease in the urea peak in this patient's urine, and that's potentially because of nitrogen conservation and anticipation of catabolism. And then when you compare control and patient, again, we see increased uric acid in the control, which is a marker of muscle anabolism as well as gut flora micrometabolites. Looking at another section of the spectrum, we see a large alpha alcohol peak for our trauma patient. We also see differences in lactate, acetate, and citrate, which among other things could be evidence of an impaired TCA cycle. We then ran the blood samples through a mass spec. Mass spec, as a reminder, emits ions and fragments molecules, and then they're separated on the basis of their mass to charge ratio, and a detector records that signal. You have a readout for what water would look like if we passed it through a mass spec. It's essentially like smashing the molecule with a hammer, deducing what it was based on the pieces that you see. You get a readout which looks like this. It's a little bit more difficult to interpret than the NMR profile. The heights are again proportional to the relative amounts of different species. We converted it into something a little bit simpler so that we can understand it better. What you're looking at is called a biplot. It's a graph on the x and y axis of principal component 1 and 2. Principal components are a set of summary statistics where they look at the major variance in metabolites between two samples. The ones with the highest variance go into component 1, the ones with the second highest variance go into component 2, and so on. So we're looking at a plot of principal component 1 versus 2. The individual data points, the individual data points are individual samples, and the ones that are close together are more similar. The ones that are farther apart have less principal components in common. And you can see actually that we've separated out our patient here from our control quite nicely. Our internal quality control standards are pretty close together, which indicates that this is a pretty precise technique. So based on our prelim data, we've shown that we can distinguish the metabolome, and we've also identified some interesting biomarkers. These are just some future directions for the research. We're hoping to distinguish between two catabolic and anabolic pathways, and hopefully shifting the metabolome in the presence of nutrition therapy. Correlating that with outcomes is another thing down the line. And then studying specific components, such as the pharmacology of nutrition down the line would be one of our goals too. And that's all I have.